And I'd like to now welcome Professor Vikram Patel, Paul Farmer Professor and Chair of the Department of Global Health and Social Medicine at Harvard Medical School, to deliver his keynote. Prof. Patel leads the Mental Health for All lab, which focuses on the social determinants of mental health problems and the use of community resources for their prevention and treatment. He is also a co-founder of Sangath, an award-winning NGO based in India, which has pioneered approaches to achieving mental health equity in the region. Today, Prof. Patel will be delivering his keynote address titled Scaling Up Psychosocial Interventions from Science to Policy. Prof. Patel was unfortunately unable to join us in person today, but he joins us live virtually here. Prof. Patel, please.
Hi, can you hear me? Can you see my slides?
Yes, we can hear you. We don't see the full screen of your slides. Now we do.
Oh, perfect. Okay, well, thank you so much for the invitation, the introduction, and once again, my deepest apologies for not being with you in person. Personal engagement suddenly showed up, as sometimes happens in life, and it prohibited my ability to actually travel to Singapore and return back to India in time. Friends, I believe there's a big audience out there. I want to greet you. I'm joining you right now from my home in Goa, in India, the location where I have lived and worked for the past 30-odd years, and where I had founded the organization Sangath, some of the work of which I'm going to be sharing with you this morning. It's a great pleasure to see such a successful event being held in Asia, and I'm hoping that we will have some time to also have a conversation about the topic that I'm going to discuss with you. In fact, I think some of the points I'm going to make are actually very relevant to some of the remarks that we heard in the opening ceremony. My talk is almost entirely about psychosocial interventions, and I really want to start by just reminding ourselves what we mean by psychosocial interventions. These are interventions that work at the interface of psychological and social mechanisms that have been well proven to be central to understanding what shapes our mental health and what leads to mental health problems, and importantly, from a recovery perspective, how we can actually get better. So the first question to ask is, what is the evidence base on psychosocial intervention? And of course, the evidence base is huge. Psychosocial interventions are indeed not only the first line, but the most effective treatments for the majority of mental health conditions, such as, for example, let's just take a few as shown on this slide: autism in childhood, anxiety disorders from childhood all the way through into adulthood, and PTSD. Even where pharmacotherapy, such as, for example, for psychosis or the addictions, are very effective, there is abundant evidence that when you add psychosocial interventions, the overall effectiveness of your treatment program is far greater. And when there is a choice between pharmacotherapy and psychotherapy, as we do have for depression, there is now evidence showing that psychological treatments they're not only equivalent to medication for remission, but they are much better for long-term outcomes in terms of reducing relapse rates. In a nutshell, psychosocial interventions have a role to play in virtually every single instance of an individual struggling with their mental health. And for the majority of those instances, psychosocial interventions are the only intervention that you need. Now, let's pause for a moment and ask ourselves the question, given this overwhelming body of evidence coming from 100 years of randomized controlled trials, clinical studies, and a variety of other study designs, how well have we been able to deliver these interventions at the front line of healthcare? Let me turn to the country which I have spent the last 7 or 8 years working in. The US is the most richly endowed country in the world when it comes to mental health human resources and when it comes to the amount of money that we spend on mental health care. Look at these statistics that have been shown on this slide that reflect and describe what proportion of people living with depression will receive the most evidence-based treatment for their depression in the world's wealthiest country. Only a quarter of those who actually seek care for depression will receive a psychological treatment. And this is in spite of the fact that the majority of patients, particularly those from low-income and minority groups, actually express a preference for psychological treatments. And all of us who are clinicians know very well that when patients don't receive the treatment that they prefer, they're much less likely to engage with it. And this is why we see such high levels of dropout from mental health care programs around the world, including the US. Now, this is a staggering observation. If the world's wealthiest country with the most human resources for mental health care, including psychologists and counselors and a variety of other talking treatment experts, is doing so badly in ensuring that the psychological treatment reaches the person who needs it, how does a low-resource country deal with this? Well, much worse. In most parts of the world, for example, across sub-Saharan Africa, South Asia, and many parts of East Asia, Latin America, Eastern Europe, there is virtually no access to evidence-based psychosocial interventions. And I want to really emphasize what one of our opening session speakers talked about: science and not snake oil. I want to emphasize that, because there is a science around which kinds of psychosocial interventions work. We have to ask ourselves the question not only whether individuals are receiving psychosocial interventions, but also, is it affordable? And is the intervention that they're receiving, in fact, backed by the highest quality science? The same kind of science that we consider essential for any medication. Are we also seeing the same kind of science being applied for psychosocial interventions? And unfortunately, friends, not only is access to psychosocial interventions very, very poor in most populations around the world, but if you look at evidence-based psychosocial interventions, this picture is even worse. So let's pause for a moment and ask ourselves the real elephant in the room question. How is it that one of the most effective interventions in mental health care, an intervention that most people with mental health problems prefer, how is it that all countries in the world, from the wealthiest to the least resourced, have utterly and totally failed to deliver these interventions? To me, this is the true crisis of global mental health. It isn't how many people suffer from mental health problems. It isn't, do we know what works? The crisis is that what we know works, what we know people prefer, is simply not actually being delivered by healthcare systems. I have looked at this question for many decades now, and here are the reasons which I have identified are primary central reasons why psychosocial interventions do not get scaled up. First of all, let us acknowledge the hierarchies of healthcare. There is no question that the more biomedical healthcare professionals, such as, for example, physicians, psychiatrists, such as the profession that I come from, are at the top of the hierarchy of healthcare. Other professional groups, psychologists, nurses, social workers, are much lower. And typically, the people at the top of the hierarchy of healthcare will command not only resource allocation, but also resources being allocated to the interventions that they have control over. And there is, of course, no surprise that medication is an intervention that only medically qualified individuals can actually prescribe. Thus, medication gets a huge amount of importance. The previous speaker actually spoke about medicating children. This is a question we should be worried about when, in fact, for most mental health problems in childhood, psychosocial interventions are not only the most effective, but indeed the only intervention that's been shown to work. Unfortunately, when we look at psychosocial interventions, there are also problems there. They're incredibly complex. You require years of university training in order to be able to deliver the evidence-based interventions that are the staple of mental health care, such as cognitive behavior therapy. And then, of course, not surprisingly, when you have to spend so many years and so much money becoming a psychologist, your guild is going to resist the application of these techniques by any other professional group. So the hierarchies don't only operate in psychiatry over psychology, but also the guilds of psychologists will then also restrict the ability of other professional groups to deliver psychotherapy. For a long time, there have been questions about whether psychological treatments which have emerged through theoretical paradigms that were primarily developed on the basis of observations made in high-income countries, and particularly fairly restricted ethnic groups in high-income countries, mostly white communities, whether these apply to other groups of people, both within those countries, but also globally. But for me, the real singular reason why psychosocial interventions don't get scaled up is because there is no money in it. Let me explain. If psychosocial interventions were a pill, and we could bottle them, and we could brand them, we would not see these dismal figures of coverage that I just shared with you. For the simple reason that medication has a juggernaut of the pharmaceutical industry that is singularly geared towards selling as many medicines as they can get people to take for a profit motive. And of course, think about it for a moment. Is there even a remote equivalent for psychosocial interventions? The answer is no. Psychosocial interventions are designed by academics in university settings, and then, of course, you publish your paper and hope that somebody will start practicing them. Not the same with medication. And of course, therefore, there is a completely imbalanced, asymmetrical competition between medication and psychosocial interventions. Now, global mental health, a field that I have been very closely associated with, of course, this is a field that lies at the interface of two very important scientific traditions: clinical science, questions about the design of effective interventions for low resource settings, and implementation science. How do you actually deliver these interventions in settings where there are very few resources and competing health demands? The focus of global mental health is to use these two scientific disciplines with a focus on reducing the population burden of mental illness, but very importantly, also reducing disparities in the population, what I call achieving mental health equity. Because we know that mental health problems are not equitably distributed in the population. People on the margins, people who are living in conditions of disadvantage and poverty, people who are escaping conflict, all of these groups are far more likely to develop mental health problems, a great telltale sign that mental health problems are inseparable from our social world. But also, these are the very groups who are less likely to be able to afford and access appropriate mental health care. So global mental health is a discipline that's really focused on these issues of equity, and much of the original research, although I'm going to show you in a moment, has really emerged from areas of the world that are under-resourced, particularly Africa, Asia, Latin America, very similar really to other areas of global health. So global mental health practitioners and scientists have been deeply engaged for the past 2 decades to address the question about how do we get psychosocial interventions to the majority of people in our context who currently have no access. And a key element of this has been, how do we address the barriers I described earlier? For example, how do we make our clinical interventions less complex? And how do we deliver these interventions in the hands of individuals who are less trained than mental health professionals, who are more widely available, who are less likely to cost a great deal to the healthcare system, so that we can get these brief interventions out to the population very quickly at the time when they actually need this care. One such example of a treatment that I'm going to spend a few moments sharing with you is a 6-session treatment for moderate to severe depression that we designed for delivery by lay people in routine primary healthcare in Goa, in India, where I'm joining you from right now. This was a program led by Sangath in partnership with the London School of Hygiene and Tropical Medicine. I'm delighted that the Mental Health Innovation Network Asia is one of the co-sponsors of the event in Singapore. I was the founder of MIN, as well as the founder of the Center for Global Mental Health at the London School of Hygiene and Tropical Medicine. This was the time in which I led this work on the design of this brief intervention. I'm going to show you a video now that takes you through some of the experiences of the various actors in that randomized controlled trial, and then I'll show you the results of that trial.
पहिले म्हाका खूब त्रास आहे 2 वर्सां जाली तकली दुखा आनी चक्कर येयल्या जा डेली तकली दुखा डेली घरातले कसले काम जायना जाय न्हिजोन रावा दिसभर भुरग्यांक सुद्दां मी लागी घेयना जाय कित्याक घरातले करिना जाय
म्हाका खूब त्रास करता घरा देव आनी तेजी बायलूय शिकयता आनी म्हाका खूब टेंशन जाता तकलेन आनी हांव बरें नासता म्हाका जेवपाची बी याद उरना आनी कितें खावचें कितें काम करचें अशें म्हाका दिसत ना आनी भुरग्यांकूय हांव केन्नाच सारकें वाडिनाशिल्लें कांय करिनाशिल्लें तांकां एक कितें करप आनी कितें घातलें आनी घालप आनी टायमूच म्हाका असो बसोनूच हांवें काडप म्हाका खूब टेंशन जाता.
With depression, we've developed a very specific treatment called the Healthy Activity Program. This is a treatment that's based on the concept that when people become depressed, they stop doing activities that they typically do. For example, there may be social withdrawal, they may not be able to keep up with their work demands, they may stop doing pleasurable activities like watching TV, reading, etc. The less they do, the worse they're likely to feel. So the Healthy Activity Program is delivered over about 6 to 8 sessions. So the main focus of the initial sessions is to get patients to become activated, to start doing things that we know will help them feel better.
कितें काम कर म्हणजे मागीर थंय रोंपो लायलो मातशें अशें भोंवंक वचोंक लागलें जावं काटयां हाडूंक लागलें शेतान मातशें वचोंक लागलें आनी कितें भाजी पालो घरा कडेन रोवंक लागलें आनी तितून मात मागीर म्हाका म्हयन्यान करून म्हाका एक 9 म्हयन्यांनी सारकें पूर्ण तकली म्हाजी शांत बरी जाली.
पयलीं तेणी 5 मिनटां कुळागरां वचून काम कर म्हणलें मागीर तेणी म्हाका 10 मिनटां दिलीं मागीर 15 मिनटां दिलीं मागीर म्हाका तें काम बरें जाता अशें दिसलें हांवें 5 मिनटां 2 मिनटां वाडोवन करप मागीर म्हाजी भुरगीं येतालीं मदत करून आनी इतल्यान म्हाजें आतां कुळकार निव्वळ आसा आनी म्हाजें कामच चालू बरीं जाता आनी म्हाका आतां वखद सुद्दां नाका बरी जाली तितूंतल्यान आनी बरी आसा हांव सामकी.
आनी आतां म्हाका खूब बरें दिसता जशी तकली जास्त दुखना केन्ना अशी चुकोन दुखता बेगीन उठपाचें भुरग्यांक शाळेक धाडपाचें जाता त्रास आहे तकली बी दुखना आदल्या सारकी.
So those are obviously highly selected actors who have been, well, they're not actors, they're actually real participants, but they were short video clips about their experiences. This is what our trial found. Take a moment to orient yourself to this slide. These findings were the 3-month findings were published in The Lancet and the 12-month findings in PLOS Medicine. So you can see details in those papers. At the start of the trial, we had 495 individuals with severe depression, not mild to moderate, but severe depression. And we had explicitly chosen the most severe form of depression because these were the individuals who were most likely to benefit from clinical interventions. 100%, of course, of both arms in the trial were severely depressed. By 3 months, 2/3 had recovered in the treatment arm as compared to just 1/3 in the control arm. 12 months later, we show sustained benefits in the treatment arm with very little additional improvement in the control arm. And 5 years later, we showed continued sustained benefits. Let me turn this around. Let me explain this in a different way. 6 sessions of about 35 minutes each by a layperson delivering a theoretically grounded psychological treatment based on the relatively simple strategy of behavioral activation led to the sustained recovery in 2/3 of individuals with the most severe form of depression in the community for up to 5 years. Just 6 sessions multiplied by 35 minutes by a layperson. Equally, though, it's important to point out that 1/3 of those individuals did not respond. And this clearly shows that a one-size-fits-all approach for mental health problems does not work. We need to tailor our treatments according to the unique needs of individuals. At the moment, we do not have sufficient information that allows us to allocate individuals to different treatment paradigms. I'm currently leading a large trial in Bhopal, an NIH-funded trial called Optimize-D, that is actually addressing exactly that question. Can we distinguish at the time of initial help seeking who is likely to benefit more from an antidepressant medication or a brief psychotherapy, which is behavioral activation? But right now, we don't have that evidence. So what we really need to do is to look at individuals recovering from a brief treatment and those who do not recover at 3 months being referred for more specialized care. Friends, this body of evidence is enormous. In fact, I would argue it is the most substantive and exciting body of science to emerge from the fields of psychology and psychiatry for the last 2 decades. More than 100 randomized controlled trials that have demonstrated how, through the design of interventions that are brief and scalable, and then attention to training and supervision of frontline providers, we can deliver interventions for prevention and care across a wide range of mental health problems. The image on this slide comes from the Friendship Bench in Zimbabwe, where Dixon Jibanda, a psychiatrist in the university there, trained grandmothers to deliver a 6-session problem-solving intervention for people with anxiety and depression, such as this mother with a young child, in routine primary health care. Again, just like my work in India, ran a randomized controlled trial, published it in JAMA, showing the large effects of this approach in leading to recovery. And turning to the global north, I've been involved with a large trial in Canada and the US funded by PCORI, which has taken exactly the same treatment, the Healthy Activity Program, adapted it for women who are pregnant and have had children. For North America, not very often you see a treatment that was designed in the global south being re-engineered for delivery in the global north. And Daisy Singler, who's the PI, has just completed one of the largest trials in North America, asking the question, when the BA treatment is delivered by a specialist, how does it compare to the same treatment being delivered by a non-specialist worker? The findings will be published in a few weeks in Nature Medicine. And in a nutshell, she observed in this trial that there was no difference. In other words, not only is the non-specialist able to deliver these brief treatments with great effect, they do just as well as when a specialist delivers the same treatment. In North America, the non-specialists were nurses, midwives, and doulas. The benefits of this approach go, of course, well beyond just simply improving access to care. They frees up specialist services for mental health professionals to work at the top of their license. It helps reduce stigma associated with help seeking. I found very often in primary care or in school settings or wherever I work, when you tell people you need to see a mental health care provider, 95% of them will simply not go because they're embarrassed, because they're ashamed, because it's expensive, because it's too far, for a variety of reasons. It's person-centered because these frontline workers aren't just mental health care providers. They're also delivering other aspects of healthcare, including for their physical health problems and their social determinants. And across this program of work, we found that this approach benefits the providers itself. This is redefining mental health care in 4 ways. Interventions are brief and psychosocial. They are delivered where people are, not where the providers are, oftentimes in community settings, including their own homes. They can be delivered by anyone who has the authority and interest to deliver psychosocial interventions. And they are done typically in a collaborative care framework where people are being supervised and supported, and patients with more specialist needs can be rapidly referred to the specialist. This body of evidence is now informing policies around the world, both at country level and importantly at the global level. As you can see, 3 Lancet commissions that I show here, as well as 3 WHO and World Bank reports, all of which have embraced the idea of a bottom-up approach, empowering frontline workers to be the army that is actually going to address mental health care in the community. And mind you, this is not just for developing countries, but indeed for the wealthiest countries in the world as well. As you can see, this manual for task sharing through community-based organizations designed for New York City, no less, the richest and the best resource city in the world. I want to end by just telling you a little bit about what I'm doing right now to actually translate this science, which has influenced policy, into practice. A key element, of course, of this science is to build the capabilities of a community-based workforce to deliver evidence-based interventions. And the old-style model of bringing these workers into a classroom, having an expert train them in a workshop, works very well for a randomized control trial when you have to train 20 or 30 health workers. But it is not fit for purpose when you have to train tens of thousands, even millions of providers in a country like India. I launched the Empower program at Harvard Medical School, as well as in Sangath in India, that seeks to deploy a range of digital tools and opportunities to enable frontline workers to rapidly learn, master, and to support the delivery of quality-assured psychosocial interventions. Now, these are not digital tools for the person with the mental health problem to try and figure out how to help themselves. You hear a lot of that, I'm sure, in these 2 days of the conference. These are digital tools for the health system to enable person-delivered care by actually building the capacity of human resources in their systems to deliver psychosocial interventions. This is a model, a program that recognizes a journey of a provider from being a naive learner, say, for example, a nurse who is learning a psychosocial intervention like behavioral activation, then practices that intervention with individuals with depression, a period we call the internship, completes a competency assessment to become credentialed, and then enters the workforce to deliver the intervention. Technology is used across this entire pathway in a variety of different ways. For example, digital curricula, which ensure that you do not need a human trainer and where you can standardize the training. But of course, you can do hybrid training where you have a lot of the content that is digital with hybrid sessions for reflective learning and role play. Competency assessments that could be delivered remotely. Supervision apps that we've designed with the Boston-based tech company Dimagi. And data-driven evaluation, particularly what I'm excited about, is the deployment of large language model, generative AI, to provide automated assessments of the quality of psychological treatments delivered by providers using large language models. Empower currently has interventions for 5 groups of mental health conditions: depression, emotional disorders and adolescence, peer support interventions for people with serious mental illness, which we will launch at the Global Mental Health Summit in Cape Town in November, which is, of course, a large peer-led group, which will be holding a major summit in November. A parent-mediated intervention for autism spectrum disorder, and a single session intervention for peri-traumatic stress. All of these are designed around the rich evidence base of clinical science on psychosocial interventions and implementation science on how these can be delivered at the coalface of care. Empower currently is in various stages of scale-up of these interventions. For example, the Healthy Activity Program is being rapidly scaled up across central India. And excitingly, in the US, we have a range of different partnerships in the state of Texas, funded by a range of funders, including the NIH, and a big prize we received for Texas. But what's exciting here is we're working with very diverse groups of providers, including community health workers, but also students of social work in one of the minority universities of Texas, and most recently working with churches, 8 churches that form the Congregation Collective, to equip their members to work in partnership with the university system there to provide frontline care to people with depression in their communities. In conclusion, friends, the majority of persons with mental health problems do not receive the high-quality evidence-based care that our textbooks tells us they should receive, including in the wealthiest countries in the world. Global mental health, particularly deploying innovative clinical and implementation science, is pointing us to a radically different approach to prevention and care. And this is through the scaling up of psychosocial interventions through frontline workers working in a collaborative care framework with specialized providers. What's truly exciting to me about this strategy is that it relies almost entirely on resources that every country has, people who care for others in their community. Thank you very much, and I hope there might be some time for some questions and discussion.
Thank you very much, Prof. Patel. We have a little bit of time for a few questions from the audience. So we have some microphones that my colleagues have just positioned on the front here. In the back, on the second floor, I have some colleagues with roving mics as well. I think what we'll do is we'll collect a couple questions, and then we'll have Prof. Patel kind of batch answer them. So if you have any questions, you can come up to the mic and ask.
So, hi everyone, good morning. I'm Asia Symposium from the Philippines. I'm also a product of the Global Mental Health program at SHTM as a scholar. And I think I just want to ask, because I think one thing we do notice, a lot of the programs are coming from the Global South, but majority of the funding for these programs are coming from the Global North. I think, how do we help bridge that gap where we do see, especially in countries like in South Asia, where there's not a lot of mental health funding, specifically to do long-term RCTs, to be able to develop this kinds of robust evidence base. Thank you.
Do we have any other questions from the floor? Would you like to come up to the microphone? Yes, feel free to collect 2 or 3 at a time, and then we'll go. Yes, go ahead. We'll run upstairs afterwards, sorry.
Thanks so much. Really interesting presentation. My name's Emma Lawrence from the Climate Care Centre at Imperial College London. So just my question was quite similar, actually. I think your point around the commercial drivers of mental health care feels very pertinent, particularly in light of the challenges we're seeing for health funding internationally, particularly at the moment with the US changing administration. And I'm seeing this in AI as well, where you noted how there's potential for big language models, for instance, to be part of evaluation. But a lot of the drivers of AI investment seem to be in, how could we tailor pharmaceutical interventions to people, rather than how can we tailor psychosocial interventions to people based on the commercial determinants. So I was just curious of where you see the levers to overcome the commercial drivers of investment within mental health and that sort of challenge for the world. And secondly, do you have a go-to resource that you would suggest for people like me who might want to learn about the world of evidence-based psychosocial interventions in general? Because there's obviously a lot of different types of psychosocial interventions, and is there sort of a Bible, you would say, of what's the list of top psychosocial interventions? Thank you.
Okay, maybe we'll, Prof. Patel, if you'd like to answer those 2 questions, since they are...
Yeah, sure, absolutely, because I guess the questions may be quite different, and also these are 2 rich questions in and of themselves. So let me just quickly be brief. to the first question, you're right, your observation is spot on. So much of the work in Africa and Asia is funded by the global north. And we do need to flip that narrative. It's completely not right for people working in these other parts of the world to be relying on northern institutions, not least because, as the second questioner asked, we're completely vulnerable to the whims and fancies of the electorate in other countries when that happens. And I think that is a vulnerability that we should protect ourselves from. And I can see that over the next few years, there will be a growing recognition, particularly amongst the wealthier countries in Asia, and there are many very wealthy countries in Asia now, that we need to be independent in the way we actually finance science, in the way we think about our economies. We cannot rely on a global order that clearly is under threat right now. And so I hope that this will be a wake-up call for the science academies, for the foundations, for governments to start investing in mental health and indeed more broadly health research in our various countries, and also for countries like China, for example, to recognize that they have a unique opportunity to step into the void that the US is leaving by becoming a major global health research partner. This is soft power. I hope that we see that happening in many countries in the global south. To the second point about commercial drivers, again, I would say it's really important to remember the NIH, which is the world's most prominent research funder, is a government tax-funded funder. And so we need to be actually asking our governments to use the taxes they collect in a way that is going to be invested in science. And that science should also be practically useful. It should be meaningful, not just lab science, which I think is terribly important, but also implementation science, which for very long has been seen as a soft science. And I think we have to convince our funders that that is the kind of science that is closest, that is in terms of actually affecting population change. You asked me finally a question of where you can find a single place for evidence-based interventions. There's so many different reviews. The problem I have with much of the evidence is that there are literally hundreds of different branded psychological treatment packages. It's really interesting. There's a parallel with the pharmaceutical industry here. And some of those packages, by the way, are proprietary. So you have to pay some company to be able to get them. The place where I am much more wedded to is the idea of brief techniques that emerge from these branded packages that are universal, behavioral activation being a good example. And I'd alert you to the Wellcome Trust's a resource on active ingredients. This is exactly the place I would encourage you to go to. The active ingredients initiative is to go away from these multi-component complex packages to very specific techniques like problem solving, mindfulness, behavioral activation, and so on, because those are the techniques you want people to learn rather than a complex multi-component package, because those are the techniques that you can apply across diagnoses and across different contexts.
Thank you very much. I'm going to go to a question on the second floor.
Hi, I'm Ted. I'm from Myanmar.
You might need to speak up a little bit. Sorry.
Hi. Is it okay?
Yeah.
Perfect.
Thank you. I'm Ted. I'm from Myanmar, and I run a youth organizations, which you might not be aware or where Myanmar is going through a civil war. So we have 55 million, but there are a lot of young people, over 20 million, and a lot of them are in highly depressed mode, and their mass suicide rate jumping up. So for us, not a primary mental health provider, but we jump in to really support our youth in times of crisis. So we're actually so my question is two components. One is questions, and one is actually ask for suggestions. So in a case like us, where they're under the context of wars and intense movement, and the mental health, essentially it's pandemic, it's going wild. So one of the people that we be engaging, over 200 people, the PHQ-9 score is actually, the average is 20, over 20. And almost 80%. So we didn't really expect that. So my question to you is, in the state where there is not a lot of resources, or not even either institutional level or funding level, so how do we actually solve this kind of pandemic crisis? Is there any open source or go-to program where we can sort of tap into, so that the people who care can bring that resources and, solve this pandemic somehow. Thank you.
Thank you. I'm going to go to this participant over here.
My name is Rainer Sauerborn. I'm from Heidelberg Institute of Global Health in Germany. I have a question regarding the usefulness or the applicability of your tool, your psychosocial intervention tool for kids, for particularly those with ADHD. One of the speakers, your predecessors, mentioned the pandemic of school children getting Ritalin and all the other drugs for ADHD. Does it work as well for these kind of youths? And thanks for a great presentation.
Okay,
Thank you. Should I take these two questions? To the first question from Myanmar, of course, I'm very aware of the terrible situation there, and which has so many different dimensions. And I have also been engaged with colleagues in Bangladesh who have been working with some of the people who've been displaced from the Rakhine province. So the question you ask is really important. Low resource settings are not uniform everywhere. Myanmar, for example, is a case in point where the entire health system has collapsed because of an ongoing civil war, when literally tens of millions of people have been displaced internally, and quite a large number have also become refugees in other countries. So what I described earlier seems completely, even that is too much, because you are expecting community health workers, social workers, working within at least some degree of an organized healthcare system, delivering 6 sessions of therapy. This is a bridge too far for many of these very complex humanitarian contexts. And with that in mind, we've been working very closely with our colleagues in Texas, where we are currently designing, on the basis of the best science we have, a single session intervention. Asking the question, what can you do in a single encounter to support someone who has actually experienced a traumatic event, losing their house in a climate event, for example, or seeing someone being killed in a conflict event? What can you do that can be done at the front line of everyday life in the community, not even health workers? So this is the ultimate idea of democratizing mental health care, is by making every single person in the community equipped with what I would consider an essential life skill of being able to support another person in your immediate social world who is having a difficult time. And of course, those are techniques that can also be very powerful for self-care. To your point about how do you access these resources, everything we do in Empower is open access. Everything is free. And the whole idea is to make these interventions that are built on decades, if not literally 50 years or more of science, widely available at no cost. After all, we're working through Harvard Medical School, which is a university whose mandate is to improve health everywhere. To the point about ADHD, that's not a condition I have personally worked with. ADHD is one of those conditions, just like depression, where you do have a very effective pharmacological option as well. And I do think that actually there is a pretty strong evidence base on the use of those medications. The problem, I think, which was alluded to by one of the earlier speakers, is the overdiagnosis. In other words, there's mission creep. What began with a very narrowly defined set of criteria for diagnosing ADHD has crept, and you can see this classically by comparing stimulant prescription rates in the US with other developed countries. It's 10 times higher in the US. ADHD prevalence is not 10 times higher in the US. But also within the US, you'll see that if have private insurance and you can access private services, you're far more likely to get stimulants than if you're not. So there are enormous questions about whether this is equitable, but also whether this is over-medicating children. We do know that there are behavioral interventions for ADHD, parent-mediated interventions, teacher-mediated interventions that are very effective. But at the moment, we do not have, I'm not familiar with a program that is trying to scale these up. It's much more challenging, honestly, because medication is such a quick fix for ADHD that I think even for parents, it's a lot more convenient to just give their kid a pill. The effects are instantaneous. They can see it like within a week. And I think, that's a very powerful driver also for treatment engagement.
Thank you very much. I want to be very conscious of time. And so I see we have 5 questions on here. If it's okay, Prof. Patel, we're just going to rapid fire the 5 questions in one fell swoop. Okay, we'll start with this delegate over here.
Okay, thank you very much. My name is Renta Krisdiana. I'm from Yogyakarta, Indonesia, and we are working with the youth health and also proactively promoting for the universal intervention for the youth through school-based mental health program. And also we're using art and creativity, which is making facilitated film dialogue for the students, teachers, and parents. My question is, despite this condition of very scientifically to address mental health problem, we noticed that this is about a very soft things hidden in our life. That's why we're using art and creativity, and how this also can be intertwined with all the scientific effort that have been placed and popular here, and making it work for all of us as a human being, as you said in your last word, which is for the building people who care. I think that's what we do. We're trying to building a community of care in our small world here. So I just want to know that whether there are an eye for the art and creativity to be placed. Thank you.
Thank you. I'm going to go to this delegate over here.
Hi, my name is Candace Powell from My Hong Kong. So actually Hong Kong is a very rich country. We have been trying to advocate for the step care model for almost like decades. So something that difficulty that I encounter, so I want to ask for your advice. So the first one is that how do we navigate the professionalism, because you have mentioned that actually in mental health that everyone is really protecting their professionalism, for example psychiatrists, psychologists, even social workers and counselors. So when we advocate lay worker to provide the psychosocial intervention, though, how can we navigate that? So this is my first question. And then the second question is that because right now in Hong Kong we are piloting, although with many pilots already, we are still piloting the step care model in the primary healthcare setting. However, one thing is that in primary healthcare setting, the group is a lot of older adults. So how can we help to shift from the older adults to general adult population in the primary health setting? So thank you so much.
Thank you. I'll go over here.
Okay, thank you very much. It was a fantastic presentation, Professor Vikram. My name is Tasik. I'm a global mental health researcher from Bangladesh and currently finishing my PhD in Monash University. In my PhD, I'm working with the deaf communities to co-design digital mental health solution, and I have some shocking findings. The deaf communities, they're even struggling to express their emotion precisely and adequately, and I think very little is going on in this space. So I want to know from you how global mental health community can support, severely discriminated and historically neglected community like deaf communities around the world. Thank you.
Thank you. Okay, we'll take one more from here and then we'll try to connect the dots somehow. Yes.
Thank you for your presentation, Dr. Patel. My name is Quan Vu, and I'm from the City University of New York School of Public Health. My boss, Victoria Ngo, has been doing depression care task sharing in Vietnam, actually for the past 20 years, actually doing behavior activation also. So my first question is, so I noticed that you have a peer supervision app. So I would like to know a little bit details on how that works. And my second question is, you said that there was a phenomenon of gatekeeping from professional guild in maybe in India, and the same thing in Vietnam, where psychiatrists are really gatekeeping psychological intervention and not really allowing other professionals. I am a social worker myself. I'm licensed in New York City. However, especially when I come back to Vietnam, I cannot practice. And other people like myself who are social worker trained in Vietnam, who are also very capable, aren't able to do psychological intervention, especially because the country is still favoring medication treatments. So I would like for you to give us a few recommendations, especially coming from a similar setting of LMIC. What would be the recommendation for overcoming this gatekeeping phenomenon, especially since we are still lacking in human resources for psychological intervention? Thank you. Okay.
Well, thank you very much. Let me try and string together my... Oh, are there more questions?
Okay, I actually would like to, this has been standing there, so if we could take one more, and then I think they'll have to cut it off from there. Sorry.
Thank you so much. My name is Usputari. I'm from Jakarta, Indonesia. I'm representing Sehat Jiwa. It's a social enterprise that focuses on promotive and prevention efforts through education. So my question is, given the hierarchy of healthcare, how can we escalate multi-sectoral collaboration in the future? Thank you.
Okay, I didn't hear the last bit of the question. Could you just speak, just say it again?
Collaboration?
Yeah, how can we foster and escalate multi-sectoral collaboration?
Okay, got it.
Thank you.
Okay, so let me just answer some of these questions. Some of them are related to each other, so I'm not going to answer them one by one, but try and lump them together. One big bucket of questions really is about territoriality. How do you implement step care? How do you create intersectoral collaboration? So I would say that there is no easy answer to this, but I wanted to share some of my own strategies that I've worked. The first is to actually not make people feel that they're useless or that their years of training have no value. I think that would be the wrong message. I think the idea of step care is very important. What it tells you is that one size does not fit all, and that there are multiple sub-stories here. Firstly, that everyone deserves care. Secondly, that they deserve care at the point when they need it rather than waiting 3 to 6 months or spending a large amount of money. That is where the frontline worker delivered care model becomes relevant. But as I showed you earlier, there will be individuals who will not respond to that, because one of the most important lessons of mental health care is that one size does not fit all. Therefore, there is a role for every single group of professionals, from the frontline worker all the way through to the prescriber. So making everyone feel they have a role, and also sort of playing to the advantages when you say that, by saying that you have spent 15 years in university to become who you are. Don't you think you should really use your super specialist skills to deal with individuals who need those skills, rather than the sort of things that can be easily managed by someone with much less training? To do this, I form alliances. Now, in the US, for example, I'm working with the American Psychological Association, which is the world's largest professional guild of psychologists. And I'm very fortunate that the CEO of the APA is someone who's exactly embraces the same values and principles that I do, but is also founded on science. So science is deeply important here. Without the science that I shared with you today, which is only 15, 20 years old, the first trial was published in 2003, so it's a very young science. You know, the honest truth is we become just ideological. So I think we now have the science, and we need to keep generating new science that is innovative, that is perhaps contextually appropriate. It's the combination of science with forming strategic alliances that I have found to be very effective. In India, my main partner is the government. So state governments, which are very actively concerned with getting mental health care out, and quite clearly see that there simply aren't enough mental health professionals, but also there's a resistance. It's not, I'll be honest with you, people think that this is a band-aid for a brief period of time until, you know, Asian countries will get mental health professionals. The US already has 1,000 times more mental health professionals in India, and I just showed you the stats. This is not about the number of, it's not just a supply side issue. People have misunderstood this. It's also a demand side issue. People in the community, even if you have a psychiatrist sitting 100 yards away, do not want to necessarily go there unless they perceive their problem to be seriously psychiatric. They will not go there for the sorts of life issues that you and I might consider a mental health problem, but most people in the world see these through the prism of their social world or social suffering, as anthropologists would use. So I think we should not ignore that that frontline worker delivered care also addresses demand side issues. One of the comments that questions had about older adults, this is an area, of course, of great importance to Asia in particular with the demographic aging that we're seeing. The most effective approach that I have seen is to fully integrate the management of common mental health problems, particularly mood, anxiety, and substance use problems within the programs for NCDs. Non-communicable disease programs are now widely acknowledged as the major health priority in Asia and many parts of the world, and mental health care is a natural issue to integrate because, of course, these often coexist. I'm sure you will have heard of the concept of multiple morbidities. These are very frequently seen as you grow older. To the point about severely discriminated, marginalized people, I totally agree with you. There are marginalizations within marginalizations, and intersectionality is an idea which is very relevant in the mental health space. You know, the gentleman asked me about hearing impaired communities, and you're absolutely correct that these are communities that have been marginalized within the mental health space as well. I personally have only experience of working with people with autism, which is another very specific kind of disability. And I feel that the single lesson I've taken from that is the empowerment of the individuals who represent those communities in very much the same way that in the broader mental health space, empowerment of people living with mental illness to be at the center of all planning and delivery of mental health care should be practiced. I want to just once again alert you to the Global Mental Health Summit in Cape Town in November, which, as I said, is the largest coalition of people with a lived experience meeting every 2 years, and this year will be in Cape Town. I would really recommend you look up the Global Mental Health Peer Network website and find ways to engage with that community. So I think I'll stop there. I'm sure I didn't. Oh yes, the arts. Yes, the arts is very important. It's an area for me, which is a personal priority in my department at Harvard Medical School. We have a Master's of Media, Medicine, and Health, which is wildly successful. And on the back of that, we are launching a major arts and global health initiative in which mental health is central. I firmly believe that activities that are artistic and culturally relevant, you know, whether it's dance, it's puppetry, it's theater, have very powerful examples of mechanisms that can promote recovery through creativity, through self-discovery, but very importantly in some arts forms through working with others in an activated way in which you actually are coordinating things, you're working with others, and you're deriving pleasure by seeing how you are making an audience happy. I'll end by saying there is a Lancet series on the arts and health led by a colleague from New York University. I would recommend you look at that because there is in fact a pretty strong science base as well that is examining how the arts can be used in healthcare more generally and in mental health in particular. So thank you very much. I know we're out of time. I'm going to hand back to the moderator. Thank you for your wonderful questions. And I'm once again, so very sorry that I can't feel the energy in the room with you.
Thank you, Prof. Patel. Yes, sorry. There's a round of applause for that.
Can I have one last question for Vikram? Just 1 second. So,
yes, go on, of course.
Vikram, Mai Hien from Vietnam. Nice to meet you again. So I just have a very quick question concerning about your book. You are famous on the book of there is no psychiatrist. And then it's translated in the different version and also in Vietnamese. And when we went translation of that book, we think that we can scale up the also recommendation from the book, but we failed. And then from your experience, see that any kinds of the solution from other countries that how to use the best use of the recommendation from the book of their no psychiatrist. It's a question. The second question concerning about your conclusion about scaling up the psychosocial intervention. And my question is, where there is psychiatrists like you, how to make psychiatrists to advocate for psychosocial intervention in which they only believe in medication as the effective treatment? Yeah. Thank you.
So thank you for your question. I couldn't fully hear the first one, but the second one I did hear very clearly, so I will answer that. And please feel free to email me and we can continue our conversation on email. So I do worry that psychiatric training in most parts of the world, you learn something in your classroom, which includes all of the psychological interventions, but you land up practicing only one thing. It is very odd. And it seems to me that psychiatrists are the losers here. The fact is that we are only practicing 20% of everything that we have learned through our science. And I can't think that that is a good thing for the profession. So certainly what I'm very emphasizing in my role in the US is to ensure that psychiatric training, we have a program on global and community psychiatry that's run through the Mass Gen Hospital, which is the main psych training program in Harvard Medical School, along with McLean. So there is a there is a specific concentration on global and community psychiatry in which psychiatric residents and training, that is to say, are actually now participating in a curated curriculum that puts them into the cold face of care. For example, working with frontline agencies with the homeless, or working with minorities serving primary healthcare centers, and so on, where they are beginning to actually get first-hand experience on how some of the principles I described to you earlier are actually practiced, and how do psychiatrists play a role in that. And the roles are quite diverse. Of course, at one level, to your question, it is to actually provide psychosocial interventions. But I think for psychiatrists, one of the very important roles is to provide leadership, to provide support, to provide supervision, to make sure that patients who are not responding to the frontline care can receive the most specialized care. It's providing essentially the leadership role that I think their training, their expertise, their high-level understanding of the field can be actually extremely valuable and reassuring. Thank you.
Okay, thank you once again, Prof. Patel, for your time and sharing your insights with us from afar. We really do appreciate it, and have a great day ahead.